On chapter number 5, and we're going to start covering rhythms within Dale Dubin's rapid interpretation of EKGs. Okay, so the first thing we're going to understand is, well, what is a rhythm, or what is not a rhythm? Okay, maybe we need to talk about it in terms of rhythm and dysrhythm. In other words, what we talk about and what we say is, instead of saying, well, it has no rhythm, we say there is an arrhythmia or dysrhythmia, which ultimately means there's a bad rhythm or means you have no rhythm. Okay, this may be seen, it may be felt within somebody's chest. Okay, individuals that feel these things might feel like palpitations, may feel flutters, may feel uneasy, may feel different symptoms, different feelings within their chest. And some people absolutely feel nothing when they have these abnormal rhythms or dysrhythmias or arrhythms, or arrhythmias, excuse me. So let's recap. We know that the sinus node is responsible for initiating the rhythm, right? That's the dominant pacemaker. It's what creates that electrical impulse and depolarizes the heart. It starts from the SA node in the right posterior wall of the right atrium, okay? And then it fires, causing depolarization. That will then propagate down through the other atrium, ultimately depolarizing all of the atrium simultaneously. That signal, that impulse, will then move down towards the AV node. Once it reaches the AV node, we have a nice small pause. Then we move into the ventricular system. We move down into the bundle of His. We'll then split into a right and left bundle branch. And then we'll find our way down to the terminal ends of the Purkinje fibers. And remember, those Purkinje fibers are what is going to be in contact with those myocytes, which will then continue the depolarization down in the ventricles, starting from the bottom, squeezing or depolarizing up through the ventricles. And that wave that will start from the bottom of the ventricles will then contract that heart muscle, ejecting blood out through the valves. Okay, so remember, 60 to 100 beats per minute is the typical rate at which the sinus node will fire. So now let's talk about, again, our first rhythm, which we're going to call normal sinus rhythm, okay? And what we need to understand about normal sinus rhythm is, because that signal is generated from the sinus node, that sinus node is going to pace at a consistent rate, at a consistent amount of impulses. It's going to depolarize the heart. So what you're ultimately going to have is you're going to have these cycles of heartbeats, or P, QRS complexes, and Ts, that are going to be sequential. And in between each one of those P's, QRSs, and T's, you're going to be able to identify that there is equal spacing between each QRS complex. Okay? That's going to help us understand our first step, which we discussed last class, or in chapter 4, when we're talking about calculating the rate, which was when we check for regularity. Okay, that means equal distance. Okay, so let's draw one out really quick. That way we can kind of see what we're talking about. We'll draw a few beats here. We have our P, our QS complex, and our T. Then our P, our QRS complex, and our T. Then our P, our QRS complex, and our T. So what this is saying when we have regularity is that we're going to have equal distance, box-wise. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 boxes. Here, between these QRS complexes and 12 boxes, between these QRS complexes. That tells me one thing, that this signal is originating from one place, okay? The other thing we're going to look at is, well, we're going to look at the shape of the P wave. And if the shape of the P wave is identical or very, very similar, okay, we can make an assumption that this cell is firing from one single cell in the heart. Right? Oftentimes, because the sinus node is the dominant pacemaker, we will always assume that it is sinus if we have a normal shaped P wave in every single beat, okay, and we have equal distance between our QRS complexes. That's how we identify whether or not we have sinus rhythm. And it's going to be easy for us to identify if we don't have sinus rhythm, or if we have an abnormal rhythm or an abnormal single beat, because that P wave will then look different. And it might be a little bit early, or it might be late, or it might change the rate completely. So say we'll just drop this down right there. And now our new rhythm down here in red might look something like this. Okay, two things occurred. The first thing that occurred here in this example is my shape of my P wave is different than the shape up here. The other thing is my spacing between my QRS complexes has changed. 1, 2, 3, 4, 5, 6 boxes. 6 boxes, 6 boxes. Okay. But one thing that we now know is down in this new rhythm, the amount of boxes that we're seeing being 6 is still equal distance, which tells me that this rhythm that I've just generated is coming from the same cell as well. However, based on the information we know about the P waves looking different, this is not from the sinus node. Okay? We make that assumption only because we have a sinus node rhythm right up here, right? A P wave that comes from the sinus node, which let's just do this and make it easier. Right, you have that P wave, a QRS, a T, and then it goes into that rhythm. Right, so now you have 2 P waves in your rhythm that you're able to identify: a sinus P wave and a non-sinus P wave. All right, so we talked about the P wave right here. Right, that's where our wave of depolarization is going to be easily identifiable, whether it's coming from the sinus node or not, because it'll give us a P wave. Our QRS complex, which we remember is ventricular depolarization, and the P wave, remember, is atrial depolarization. And then the T wave is the repolarization of those ventricles. Okay, so before we move on to sinus arrhythmia, we're going to back up just a little bit, because we talked in class about, well, what happens if it's not between 60 and 100 beats per minute? Well, what happens if it's less than 60 beats per minute? Well, we had a term for that. We called it sinus Brady. Sinus Brady. Well, in reality, less than 60 really just means Brady. We call it sinus bradycardia if all of these things are true here. We have equal distance between the QRS complexes, and we have P waves that look the same in every single beat. That plus regularity plus less than 60 beats per minute means sinus bradycardia. So it has to be same P waves, same P's, okay, regular, right, meaning equal distance, okay, and less than 60 beats per minute. That means sinus bradycardia. And then on the opposite side, when we talked about sinus tachycardia, and if you remember, tachy means greater than 100, okay? All of this must be true. Same P's and regular, right? But now we have to be greater than 100 beats per minute. And that means sinus tachy. That means sinus tachy. All right. So now we'll talk about sinus arrhythmia. So with sinus arrhythmia, because it has that term sinus in there, we should understand that this rhythm is still coming from the sinus node. So a sinus arrhythmia still comes from the sinus node, right? But something else is making it off rhythm, okay? Or arrhythmic, without rhythm, right? So what actually happens here is we're gonna have changes not based on different cells firing like that example that I gave, but this is some type of a normal physiological mechanism that happens in our body, which alters the rate at which our heart will fire, okay? Remember we talked about the autonomic nervous system, right? The sympathetic, right? And the parasympathetic. Right? Sympathetic will increase your heart rate. Parasympathetic will decrease your heart rate, okay? Well, the sympathetic nervous system is actually stimulated when you take a breath in with inspiration. So when you breathe in, so you breathe in, and then here you breathe out, we're going to have changes in our parasympathetic and sympathetic response. All right? So I'll put heart rate up, heart rate down. So that means when you breathe out, your heart rate's going to slow down. And if I breathe in, my heart rate will then speed up. Well, when we're talking about regularity, again, we're talking about that spacing in between the QRS complexes. Well, what's that going to look like if I breathe in? Well, if it's faster, that means my spacing is going to be closer together. But once I start exhaling and breathing out, my spacing is going to spread out. Okay. So as you breathe in, you're going to notice that your QRS complexes start to get closer together. And then as you breathe out, they slowly open up or widen out. Okay. So think of like an accordion, right? Goes in and out. Think about that with your pattern of breathing, but your accordion is your QRS complexes, right? You breathe out, breathe in, breathe out, breathe in. Okay, and that's the changes that you're going to see in your QRS complex, where as you're breathing out, your spacing is increasing. So 1, 2, 3, 4, 5, 6, 7, 8, 9. But in this one, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay, and then as you start breathing in, it'll slowly start to get closer together. One cue here is that, remember, because this is from the sinus node, as it is sinus arrhythmia, okay, as it is sinus arrhythmia, it's going to have the same P waves, okay? So you're going to identify the P waves all look the same. However, the difference here is your rate is changing. Your spacing in between each beat is changing. So that's what's different between normal sinus rhythm, sinus brady, sinus tachy, where you also have the same P wave. However, you're going to have changes in your rate based on what the QRS complex is doing. Okay. So here's an example on the PowerPoint where you have an inhale, QRS complexes get closer together, like up here. And then during the exhale, they expand and they spread out a bit more. Okay, and if you look at your PowerPoint, slide number 6, I believe it is, you're actually going to see a nice EKG strip of a sinus arrhythmia. Okay, so now we're going to talk about rhythms that originate from the atrium. And when we're talking about the atrial conduction system, we need to know the different types of tracts that there are. Okay, we have a right atrium, which has an internodal tract from the anterior portion, the middle portion, and the posterior portion, okay? And then we also need to know about Bachmann's bundle. And Bachmann's bundle is the pathway in which once the SA node fires, which is located in the right atrium, right, that signal must then get transmitted over to the left atrium, because remember, both atrium need to contract together. So when the sinus node fires, that signal goes down through Bachmann's bundle and it innervates, okay, or makes contact with the myocytes within the left atrium so that we get contraction at the same time. So Bachmann's bundle is important because it's what's responsible for innervating or depolarizing the left atrium. So here are your internodal tracts. If you're taking a look at your PowerPoint, originates from the SA node. We have a posterior, a middle, and an anterior tract. Okay. All right, so when we're talking about the AV node, we've talked about the reason why we have that small baseline pause after the P wave. That's again to allow the blood to move from the atrium down to the ventricles. Okay, and then as we move further down our ventricular system, we go into the bundle of His, the bundle branches, and the Purkinje fibers. And we remember that's what gives us our QRS complex. Okay. All right, so when we're talking about ventricular depolarization a little bit more, it's going to be beginning midway down the septum of the ventricles, right? And then it's going to split, right? And then you get your bundle branches, and then it's going to then innervate the rest of the ventricles via the Purkinje fibers. All right, we've talked about overdrive suppression to a certain extent, right? We talked about this pecking order. You have the sinus node, then the atrial cells, then the junctional cells, then the ventricular cells. And each one of them have their own specific, right? They have their own specific rate at which they will depolarize and pace the heart if they are called upon to be the pacemaker, if any of the other cells above fail to fire. Okay. So let's take a quick peek at how those things are going to change just a little bit, right? As we talk about some of these other rhythms. Okay. So let's start with the sinus node. SA. Oops. And we have atrial. We have junctional. And then we have ventricular. Okay. All right, so on the left side, what I'm going to do is I'm going to kind of draw where it originates from the heart. All right, so in the sinus node, actually, let's do this. We'll make it a little bit larger. That way it will be easier to see. Okay, the sinus node is going to be here, right? That's your SA node. Okay. And then our atrial cells can be any one of these cells in here. Right? Any one of those blue dotted cells. Junctional cells, they live here, that area between the ventricles and the atrium. Okay. Right in there in red dots. And then you have your ventricular cells, right? Which are going to line the ventricles and even some here in the septum. Okay, so these are your ventricle cells. Now, because of this pecking order that we have, right, there are some rules and some changes that we're going to be able to see, and it's going to help us identify where these cells are coming from. Okay, so when you remember, we talked about a sinus beat, it's got to have a P wave, it's got to have a QRS complex, it's got to have a T wave, right? And the spacing between those QRS complexes are also regular, meaning equal distance apart. Okay, and then it depends on the rate, which will give you normal sinus, sinus brady, sinus tachy. Some other things to take into consideration, though, is when we talked about recording and rate last time, we talked about this idea of these intervals, the PR interval, the QRS interval, and we talked a little bit about the QT interval. Okay, for sinus rhythms, the PR interval and the QRS interval need to be within those normal ranges. So if you don't remember what they are, I encourage you to look back at your notes and see what your PR interval and your QRS interval are. Okay, so let's go to the sinus node. So the sinus node is going to have a P, a QRS, and a T. Okay? And it's going to have normal, PR, and QRS. And it's also going to be regular. So it's going to look like that, P, QRS, and a T. A P, a QRS, and a T. Okay. Now, that tells us, hey, I'm coming from the sinus node. And when I depolarize from the sinus node, I will then contract all of the atrial cells simultaneously, left and right. Remember, it goes to the left through Bachmann's bundle. That all depolarizes because I start the impulse at the sinus node. It will then go down through the AV node. So once the sinus node fires, all of these other cells will ultimately fire because that's how the wave of the impulse or the wave of depolarization goes. When one fires, the rest all below it will then fire sequentially. Go through the AV node, which means I'm going to have my pause, let blood move from up here, down here. Then I'm going to move down my ventricular system, my bundle of His, my bundle branches, and then my Purkinje fibers, and then I'm going to squeeze from down here, and then blood is going to shoot out. All right, so remember, when this is done depolarizing, that's going to give you your P wave. When this is done depolarizing, that's going to give us our QRS. And then remember, our T wave is that phase where we're going to go repolarize. So we're going to relax those muscles so blood can then fill again. So from atrial cells, and remember the sinus is 60 to 100, right? So atrial cells, it's going to have a P, a QRS, QRS, and a T. Let's make this P a large P. Okay. All right. You'll likely see a normal PR interval, not always, because there are some rhythms where you might not even see a PR interval or a P. And we're going to talk about those shortly. Okay. The other thing is you're going to have I want to say different shaped P wave compared to what we expect from sinus. PR interval's QRS interval is going to be normal. Right. The QRS interval is normal. So we're going to have something like this. And this is just, not always, but just to make it easier for you to identify the differences in the P wave, we'll make a spiky P wave. But then the rest is the same. Why is the P wave different? Well, because it comes from a different part in the atrium. It's not coming from the sinus node, so maybe it's coming from over here. So that pathway that it goes to depolarize everything provides a different shape. But everything below the atrium is the same because once it gets through the junction, everything else is the same. It doesn't care, down here doesn't care where it starts from up here, right? These cells down here don't care which one of these cells up here start the rhythm. All it wants to do is be able to contract and send blood out. That's its job. Okay, so that's why we have different shaped P waves because they come from different areas. Okay? But everything else behind that is the same. Okay, so what did we call the junction again? The junction was that area that connects the atrium and the ventricles. Well, we know that the P wave is atrial contraction, right? Which is why we get our P wave. Okay. And then our QRS complex is ventricular contraction. That's why we get our QRS. Okay. But the junction really isn't anything per se, except for that little time period that's paused to allow blood to move from the atrium down to the ventricles. Right. However, we did talk about that there are cells there. So because if we have a cell that fires from the junction, right, it's not from the atrium and it's not from the ventricles. So if it's from the junction, everything below the junction doesn't change. So it's going to look like this. Your QRS complex and your P wave are going to be the same for a junctional beat. Well, because it doesn't originate from the atrium, that means I'm not going to have a P wave. I will not see a P wave. So my junctional beats are going to look like this. Here, there's my pause and conduction, right? My typical pause to allow blood to move. A QRS and a T. I will not have a P wave sometimes. Okay. The other option in which you can identify a junctional beat, right, is, so I'm going to put or you may see an inverted P wave. You might see an inverted P wave, an upside down P wave. If you see either no P wave or an upside down P wave, that's a junctional beat. So here's why. Right, we talked about no P wave, right? Because the atrium don't fire. The atrium doesn't fire, right? The signal doesn't originate from there. And remember, this is just the tract. Sinus node, atrial, junction, ventricle. Every single beat. Sinus, atrial cells depolarize, junctional cells, ventricular cells. Okay, that's the pattern. Well, if the signal originates or the impulse originates from the junction only, then, hey, I don't need to go backwards per se. Right? So if I start here, I'm just going to go down because my goal is to get the blood from the ventricles out. But sometimes what might happen is you might have a cell that fires closer to that entry path, that pathway of the AV node, where we're getting signals from above in the atrium. And if it fires from here, sometimes it goes backwards. And remember what we talked about last class when we were talking about recording, right? If we're going away from the wave of depolarization, we're going to get inversion, which is why in AVR we have an upside down or an inverted view. When cells fire from the junction and originate from the junction, if they go backwards, which is what we call retrograde depolarization, if they go backwards, it's going to give us an upside down P. So let's talk about this really quick. So we're going to say no P wave or upside down. Okay. All right. It's going to be regular, right? So this one is also regular. All right. And remember, it's regular because if it continues to fire from one cell, it will always give us that same spacing. Okay. And you're going to have normal QRS interval. You'll have a normal QRS interval. Why? Because, again, it starts from above the ventricles. Ventricles don't care as long as they get to depolarize together. All right. So we have a sinus beat, an atrial beat, two junctional beats. Now we're going to talk about our ventricular beats. Okay. We're going to come down here. Now, when we have a ventricular beat, remember those are the ones that are pacing between 20 to 40. Okay. If one over here fires, it's going to depolarize and send the signal that way and this way, right? And then what's going to happen is it's going to have to go back up this way, up the bundle branch, up to the other bundle branch, and down through the Purkinje fibers, so then we depolarize. That's going to take a lot more time than if the signal came from above, where we're going down and splitting, right? Because then when we split, they're going to happen at the same time. That's even better, right? And that's the reason why we have a narrow QRS. But because if we have a cell that fires from the ventricles, when one cell fires, it has to travel to the opposite side of the heart, right? So if it starts in the right ventricle, it depolarizes the right ventricle a little bit ahead of depolarizing the left. That's going to lead to a wide QRS complex, or wide QRS interval. Okay, there's going to be no P wave, none whatsoever, because it's starting from here. And remember, when we're in the ventricles, all we care about is getting that blood out to the body at that point. Okay. All right. And again, this will be regular. So what you might see is something like this. Oops. Same shape tells me it comes from the same cell. Same spacing or regularity tells me it comes from the same cell. So take this picture here, right, where you have 3 beats, and now recreate either this one or this one with 3 beats with equal distance. That's what makes it regular, right, because it's coming from that one cell. Okay. You're going to be able to tell the difference between where it originates from based on the shapes like this, because what you know about what it will look like depending on where it originates from, as well as if there are multiple different shapes for P waves or QRS complexes. Okay, so remember, SA node 60 to 100, atrial is going to pace some shape maybe like that from 60 to 80. Junctional cells, 40 to 60, and then 20 to 40. That's why this one is super wide. All right. The faster they are, then the closer together the QRS complexes become. All right. So this is kind of an introduction to our premature beats and escape beats. So we kind of jumped a little bit ahead, and I think it's going to really help put things in perspective as we start talking about our irregular rhythms. So the first thing we'll do is we'll talk about those irregular rhythms, a little bit about why they happen. So some of the causes for your irregular rhythms are going to be because of hypoxia, meaning low oxygen, ischemia, poor blood flow to the coronary arteries, right? Too much sympathetic stimulation, drugs, electrolyte disturbances or imbalances. Some really slow heart rates can lead to different types of arrhythmias because it puts your heart in an alarm phase, or too much stretch on the myocardium, right? So things like too much stress can really lead to strong depolarizations, increasing repolarization, pulling on the myocardium, irritating those cells, leading to some type of arrhythmia. Okay, so we're going to talk about our 4 basic irregular rhythms, right? Some of them are extremely common, some of them are less common, but it's going to be easy for you to identify based on understanding what it is, what it means, and how it should look. Okay. So the first one we're going to talk about is wandering pacemaker. So with wandering pacemaker, that means you're going to get signals that originate from different parts, including the SA node. So let's get back on the board here and let's draw our heart. All right, here's your sinus node. So in wandering pacemaker, it's stating that we're going to have different cells within the atrium firing, okay? Which ultimately means if we have different cells, our spacing is going to change. Step 1, check for regularity. Okay, So that means we might get a cell, the sinus node fire, maybe that's number 1, maybe this is number 2, over here is number 3, all right? Okay, maybe over here is number 4. All right, so now we have 4 different cells that fire within the atrium. Okay, because 4 different cells are firing, that means I'm going to have 4 different shaped P waves. So maybe it looks something like this. Well, that's a sinus beat because that one looks really nice. Okay, and then maybe the next one looks like that. All right, but you look at the QRSs, they look the same, but we have a different P here. We have a P there and a P there. All right, we're going to call this one, because it looks different, P prime. P prime dash 1. Okay, let's move on. P prime dash 2. Why? Because that P is different than that P. And P prime dash 3. So how many different P waves do I have? 1, 2, 3, and 4. And remember, my spacing is going to be off. Oh, I think I made this one too close, but 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Bear with me. Let's pretend that this is 12 and this is 10. And then this one is 19, right? Okay. Different P waves means I'm getting different spacing in between, right? So that's what wandering pacemaker means. We're going to have different P's firing from the atrium to pace the heart. It's not always our dominant pacemaker, which should be the sinus node. So that's not a good thing, right? Because we want consistency, especially when we're talking about things from the heart. Okay. So when those cells from different areas are firing, it's going to lead to different spacing and different shaped P waves. But overall normal range of your rate, of your heart rate, is still going to be somewhere between 60 to 100 beats per minute. 60 to 100 beats per minute. Okay. So remember, P prime, that's what we're going to call this, P prime. So here's an example of what a wandering pacemaker is going to look like. You're going to have different shaped P waves. So if you're looking on the PowerPoint, you're going to see under wandering pacemaker, we have 1, 2, 3, 4, 5, 6 beats there. And some of those beats will repeat. Okay, some of them won't, right? Some of them are going to look different. You're going to see some that are actually upside down and inverted. Okay, so those might be junctional, but they're coming from different parts of the heart, ultimately making it, hey, well, this is what we're going to call wandering pacemaker. Okay, so with multifocal atrial tachycardia, which is your next one, multifocal means multiple cells. Well, that's the same thing as wandering pacemaker. We had multiple cells firing, right? Atrium, well, they're coming from the atrium in wandering pacemaker also. What's the difference here? Tachycardia. So what this is, so multifocal atrial tachycardia is pretty much the same thing as wandering pacemaker when you're identifying it on the EKG. However, to differentiate the two, MAT, multifocal atrial tachycardia, is going to be fast because that term is tacked on there, tachycardia, which means greater than 100. Now you're going to see this many cases with COPD patients. A lot of my patients that I work with have tachycardias because a lot of their medications, a lot of the additional stress on their heart because of their poor pulmonary function leads to this type of a dysrhythmia. Okay, so again, you're going to have different shaped P waves, right? And you're going to be faster than 100. So sometimes this is associated with digitalis toxicity, which is a toxicity based from a medication, right? And it can lead to some type of arrhythmias like this. So under multifocal tachycardia, atrial tachycardia, you're going to see an example, and you're going to see multiple P waves. Again, some P waves will recreate themselves, meaning you might see P prime 2 a couple times, but you're also going to be able to see the different types of P primes as well as the sinus beats every once in a while. Okay, the next one we're going to talk about is atrial flutter. Atrial flutter. Okay, so with atrial flutter, we're going to have one cell, and it's going to be very, very upset. So you're going to have one cell here, and he's going to be mad. So he's not a happy camper, right? So what he's going to do, he's going to get really mad, and he's going to start firing really, really fast. He doesn't care if the entire heart has finished depolarizing. Okay, he doesn't care if the atrium has sent that signal. He's going to continue to send signals. So he's going to be a really angry, really strong cell that's going to fire, and he's going to look something like that. Okay, from the atrium, right? From the atrium. So if it's from the atrium, these are going to be P waves. Now there's a specific pattern in which atrial flutter you're going to see. You're going to see a sawtooth pattern. That's why we got a little saw on our PowerPoint, the teeth of the saw. And then every once in a while, right, it could be at random, or it could be at a consistent rate. The sinus node will accept one of these cells' impulses to come through the AV node and then depolarize the ventricles, and then you get a QRS complex. Okay, but remember, he's still angry and he's still firing, so you're going to get right back to doing this. 4 QRS. 1, 2, 3, 4 QRS. 1, 2, 3, 4 QRS. Okay, that's atrial flutter. Why? You see a sawtooth pattern. Maybe it's 4 beats. Maybe it's 2 beats. Maybe it's 3 beats. Maybe the beats are going through at random, where now you have 1, 2, up, 1, 2, 3, up, 1, 2, 3, 4, 5, 6, up. This would be an irregular atrial flutter. Okay, so a quick quiz for you. All right, which method are you going to use to calculate the rate for an irregular rhythm versus a regular rhythm? Right? Remember, when we have regularity, if you've already watched, and you should have watched the chapter 4 video, you can use the different methods that we've discussed to calculate the rate for a regular rhythm. There's 3 of them. Right? The most accurate one is the 1500. The 1500 method. Okay? So 1500 minus the total number of small boxes between 2 similar QRS complexes. Let's say it's 10. So that gives me a rate of 150 beats per minute. Can I do the same thing down here with this irregular? No, I can't, because my space in here might be 10, but my space in here might be 16. Which one am I going to take? I don't take either. I don't want to use that one. I'll use the 6-second method. I'll use the 6-second method down there. Okay. So this is atrial flutter, right? You're going to have one strong atrial cell that fires, and then the AV node is going to allow one of those impulses to go down into the ventricles to depolarize. Okay. Oftentimes, you will have a regular atrial flutter. It's very rare that you'll see an irregular atrial flutter, but I have seen those live. It's actually pretty cool. Okay, so that's atrial flutter. So now let's talk about atrial fibrillation, which is a very, very common irregular rhythm. Many people have atrial fibrillation. So now with AFib, this is, again, the most common irregular rhythm that there is. You're going to have multiple atrial cells firing erratically. Okay, so it's not just one, It's this one, 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 this one. All of these are all trying to fire at the same time. Unlike atrial flutter, where it was just one, this one is multiple. I don't know which one. All of them, who knows? They're all trying to fire at the same time. So not just one cell depolarizes the atrium completely. Okay, because when we get atrial depolarization, we get a P wave. But now if we have multiple cells trying to fire, it's doing this. We don't get full depolarization of the atrium because once one stimulus originates, another stimulus originates, then another stimulus originates. So we don't get full depolarization of the atrium. Now this is actually dangerous, especially if it goes undiagnosed, because if we don't get full depolarization of the atrium, that atrium is just kind of shaking a little bit, as opposed to contracting to send blood away. And if it's just shaking there, that blood's just hanging out there. That increases the risk of blood clot formation, okay? So that's why a lot of people have to be on blood thinners or anticoagulants to prevent that blood from clotting up. Because if it clots, it can go into your heart, it can go into your brain, it can go into your legs, you can get a heart attack, you can have a stroke, right? Or you can have a pulmonary embolism go into your lung, right? Or it can go down into your legs and give you deep vein thrombosis, right? So you don't want any of that. So you don't get one single cell that's completely depolarizing the atrium, which is a bad thing. So you're gonna get something like this, but then you're gonna allow, one of them is gonna be allowed to get down through the AV node, and then you're gonna have a QRS complex. But again, because these signals within the atrium are so strong, you don't get to see a T wave either. Just like in A flutter, where as soon as we had our QRS complex, we were back into that sawtooth pattern. Here, we're going to be right back into this jumble of partially depolarized P waves, okay? And because we don't know which P wave is going to be responsible for sending that signal or that impulse all the way through, this is going to be an irregular rhythm. So your spacing is going to be way off, all right? There's going to be no consistency. So here, this is going to be the 6-second method to calculate the rate. Okay, 6-second method to calculate the rate. Your QRS is normal, so it's going to be within range, unless we have bundle branches, which we'll talk about. Okay, so you're going to have a narrow QRS and a very irregular space QRS complex intervals. So, okay, this is AFib. You're going to have something really wild down here on the baseline, because you're not going to get one single cell that's depolarizing the atrium. So here's a comparison. If you're looking at your PowerPoint, it's going to say atrial flutter versus atrial fibrillation. On the top one, we have atrial flutter, and that's our sawtooth pattern, right? So you have 1, 2, 3, then a QRS, 1, 2, 3, a QRS, 1, 2, 3, a QRS, right? And it has that sawtooth pattern. Compare that one to the bottom, and you're going to see that you cannot discern. The P wave is undiscernible, right? You cannot identify one P wave, and you're going to say, I can bet $100 on that. That's one P wave. Can't do that with the one on the bottom, right? It's so erratic because so many P waves are trying to fire, and they're incompletely depolarizing the atrium. But every once in a while, a signal gets passed through into the AV node down to the ventricles, and then we get our QRS. All right, now we're going to talk about sinus arrest. So with sinus arrest, it's there's two different types of instances in which your sinus node may fail to fire. And we're going to first start talking about, well, what happens when that sinus node fails to fire? Because at times it can happen, and it can lead to dysrhythmias or arrhythmias, or even death, okay, if you don't pace again. So sinus arrest is when the sinus node fails to fire, meaning we've been pacing through the sinus node, you have a sinus beat, sinus beat, sinus beat, and then it stops. This is problematic, okay? So what was going to happen is, because we have these different rankings of different cells, right? Your sinus node, atrial cells, junctional cells and ventricular cells, if that sinus node fails, it's up to one of these other three cells to pick up and start pacing the heart. So that's what we're going to start talking about. So if the sinus node does fail, the next opportunity that arises is going to be that of the atrial cells to start picking up the slack. Okay, so let's take a quick example on the board of what that might look like. So say you have sinus beat, okay, and then another sinus beat, and then we missed a firing cell. So the sinus node fails to fire. So failed, SA, okay. Now, we classify a failed sinus beat as a longer pause, or the ceasing of firing of the SA node that is longer than one of those R to R intervals. So that means whatever this back-to-back R to R interval is, so say it's 15 boxes. So if I get 15 boxes here, right, I should have had a QRS complex right there. So because I did not, that tells me we have a sinus arrest. Okay. All right. A couple things can happen now. Once this fails to fire, we're gonna have four options. Four options are gonna occur. The next beat that turns on can be the sinus node, atrial cell, a junctional cell, or a ventricular cell. Okay. So if the sinus node turns back on, then we'll resume pacing. Okay. No problem? Well, I guess no problem. So we would classify this as, if that's 15 boxes, that makes this rhythm 100 beats per minute. And I have a P, a QRS, and a T. So this is sinus rhythm, normal sinus rhythm. Now I have to include what happened here. It's like reading a book, right? Read from left to right. So I have normal sinus rhythm. Now I have to classify this portion right here. The SA node fails to fire because I had 15 boxes here and it missed. There's nothing there. It's absent. Okay, let's go to the next beat. What is that next beat? Well, this beat here is the same as those. Okay, so these beats are sinus. This beat is also sinus. So now I have sinus rhythm again. Okay, so say I have another sinus beat here. So now I have normal sinus rhythm, and say this is 15 boxes, and now I have normal sinus rhythm here. So I'm going to classify this and interpret it as normal sinus rhythm with SA node fails to fire. We classify that as sinus arrest. Why? Simply because that SA node turned off, okay, and then it turned back on. That's the most basic thing, explanation of sinus arrest. The sinus node turns on and then turns off and then turns back on. Okay, that's how we would write it out. Okay, and we would also add our rate in there, right? 15 boxes would be 100 beats per minute. All right. Okay, so that's the first example of what can happen. Okay, so now we're going to refresh our memory of what we just finished discussing regarding our different beats and how they're shaped and what they're going to look like. Okay, so remember we have our sinus beat. So we have our sinus. Okay, atrial. All right, so now our P wave is different. Everything else is the same. Okay, we have two junctionals, right? your junctional. And then ventricular, where you have a wide QRS. So ventricular, you got your wide QRS. Okay, so now let's say we have a sinus arrest again. But this time, we have an atrial beat that follows that sinus arrest. So now we have we have one beat that has a different shaped P wave than prior. Okay. And now that continues. Well, ultimately what happens is, because this is normal sinus rhythm, we have this failure of the sinus node to continue to pace. We call it sinus arrest. Now we have an atrial escape rhythm. That's a funny term. I know it's atrial, right? That makes sense because my P waves are different. But why is it a rhythm? Well, because I have two back-to-back. Just like I have two back-to-back here, I can classify it as a rhythm. I need two beats to classify a rhythm. Okay. And I know it's an atrial rhythm because now this P wave and this P wave, P prime 1, is the same here, P prime 1. Okay. So we would say this is normal sinus rhythm with sinus arrest and atrial escape rhythm. Move that. So normal sinus rhythm with sinus arrest and atrial escape rhythm. Okay. So by definition, whenever we're talking about an escape, that means this. So what I can really say is normal sinus rhythm with atrial escape rhythm. Okay. Now the cool thing is, because now we know what this is, right, we understand this, and we understand that depending on where the cells originate, the signal originates, the impulse originates from, we're going to have different shaped heartbeats, right? Atrial cells will have different looking P waves. Okay. Junctional cells are going to have either no P wave or an inverted P wave. And ventricular cells are going to be really wide and slow with no P wave. Okay. So if I do something just as simple as doing this, I've now changed my answer to not atrial, but because now I have no P wave, this is now junction. Junctional escape rhythm. Okay. So that's a simple way to kind of go about this. You make sure you understand these, right? And when you're identifying following a sinus arrest, you want to be able to identify that next exit beat. So we call the first beat that comes after that sinus arrest an exit beat. Okay. So you identify your exit, you're exiting your sinus arrest, your exit beat. Identify that one first. What does that shape have? What does that P, QRS, and T look like? Okay. If it has no P wave or upside down P wave, then we call it a junctional escape. Okay. If it has a different shape P wave than the P waves before it, then we call it an atrial escape. If it is a wide QRS, then that exit beat looks like this one here, and we're going to call it a ventricular escape. A ventricular escape. Okay. So again, let's kind of go back and talk about this term escape. Right? And I think we did talk about that a little bit ago when we talked about this idea of overdrive suppression. Okay. Overdrive suppression is saying that these different orders of cells, sinal, atrial, junctional, and ventricular, have their specific rate. Okay. And if a sinus node is firing, like right here, it will then suppress all of these other cells below it, meaning it will not allow the atrial, junctional, or ventricular cells to try to pace the heart, as they too have automaticity, because the sinus node is pacing. So when the sinus node is pacing, it will suppress all of these. If the sinus node is not pacing and the atrial cells are pacing, then the atrial cells will then suppress these last two. And finally, if the junctional cells are pacing, it will suppress the ventricles. But at any time, any highest order cell can take over pacing the heart. But if the sinus node is pacing, it will suppress everything else down below it. Now, the reason we call this escape rhythms and escape beats is because of this failure to fire of the sinus node. So what happens is the sinus node here turns off. It fails to fire. Well, the atrial, junctional, and ventricular cells over here are typically suppressed by the sinus node. But because it now failed to fire, the next cell capable of pacing the heart is the atrial cells. It will escape this overdrive suppression and then pace the heart. In this example now that we've gone through onto the board, well, that's not an atrial cell, right? That is a ventricular cell. So here, in this example now, we have sinus rhythm, a sinus arrest, and a ventricular escape rhythm, where the ventricles have escaped the overdrive suppression of the sinus junction and sinus atrial and junctional cells to now start pacing the heart. Okay. So what we're talking about is I'm going to escape this kind of hold that you have on me because you guys are not responding, and I'm going to start pacing the heart. Okay. So now this turns into not junctional escape, but ventricular escape. Ventricular escape. All right. So the way we write it is normal sinus rhythm with ventricular escape rhythm. Okay. So now this is a different rhythm, right? We've just covered 3 different rhythms. We have normal sinus rhythm, right? Now we've just covered atrial escape rhythm, junctional escape rhythm, and ventricular escape rhythms. Okay. Because what you might see every once in a while is if you ever get an EKG that you come across, you may not have any sinus beats at all, and you may just have something like this, where you have no P waves. Well, we're going to call that a junctional escape rhythm. Junctional escape rhythm. A JER, right? Why is it junctional? Because I have no P waves and I have a narrow QRS. Because here I have in a ventricular escape rhythm, I have no P waves, but I have a wide QRS, right? That's why that one's wide up there. Okay. So I can have a junctional escape rhythm, an atrial escape rhythm, and a ventricular escape rhythm. Okay. We're going to go over some examples in class of what those will actually look like. Okay. But this is for you to understand this idea of overdrive suppression and escape rhythms, right? At the beginning of our video recording today, and at the beginning of chapter 4, we kind of talked about, well, let's break down the differences of how these beats coming from different parts of the heart are going to look. And then what we're going to do is we're going to associate the shape of the P wave, the QRS and the T, and that's going to help us identify, well, what type of rhythms we have, what's going on. Okay, the other thing to remember is these rates, 60 to 100, 60 to 80, 40 to 60, and 20 to 40, will also be associated with these types of rhythms. So this one is junctional. So this is likely going to be somewhere between 40 to 60 beats per minute. 40 to 60 beats per minute. Okay. So those are your escape rhythms, right? So the way I like to help people identify and remember escape rhythms is they come late, right? It was supposed to land here. I was supposed to have a QRS right there, but I didn't, right? It came behind that. So it was later than it should have been. Okay, so we don't like that, but it's easier to identify. Okay, so it's important when you're checking these strips, when you're analyzing the EKGs, you want to measure the distance between each QRS that is the same, that are similar shape. Okay, and you're checking for regularity, that equal distance. Here we identify I don't have equal distance to the next beat. Not only that, that beat is differently shaped than these two beats. So my goal is to identify this beat, understand where it comes from, and then make my interpretation. It's a wide QRS, I have no P wave. Wide QRS, no P wave. Well, those tell me they're coming from the ventricles. The ventricles like to pace somewhere between 20 to 40 beats per minute. Okay, and then you would calculate your rate for your rhythm here. So in reality, when you're providing your rhythm, you're going to give me that rhythm. You're going to include this rhythm, normal sinus rhythm with the ventricular escape rhythm. So normal sinus rhythm is 100 beats per minute. Well, maybe this one is only 40 beats per minute. Or no, let's do 30 beats per minute. Okay, 30 beats per minute. And those are your escape rhythms. So let's go back to where we were in the PowerPoint. So after talking about sinus arrest, this idea here on the PowerPoint on slide 23 says escape rhythms, atrial escape rhythms. Yeah, we know they're atrial, so they're 60 to 80 beats per minute. Well, they're going to have a different shape P wave, which we showed earlier, right? We had a P prime, different than this P. So we classified it as a atrial escape rhythm. So here's an example on your PowerPoint where you're going to have this long pause, right? That's your escape, right? That's your sinus arrest. That long pause is your sinus arrest, okay? And then that beat that comes after it, depending on what it is, if it's sinus, then we just classify it as X rhythm with sinus arrest, okay? So our normal sinus rhythm, sinus brady, sinus tachy with sinus arrest. Then if that next exit beat here is different, then we classify that as a different type of rhythm or beat, okay? So now we got to talk about what's called a sinus block. Okay, so a sinus block and a sinus arrest are a little bit different. All right. Let's say another 15 boxes is going to be right here. Okay. So this will be 15 boxes also. Here's how sinus block and sinus arrest are similar. They're similar in the sense that the sinus node will stop firing. They're dissimilar in the sense of when they resume firing, when that beat comes back, when that cell starts firing and when that rhythm picks up. Okay, so remember, we can have sinus arrest and then we can have the sinus rhythm turn back on, or sinus node turn back on. Okay. So if the sinus node turns back on right here, we're going to classify this one as sinus arrest. If it turns on right here, let's do this. Okay. If it turns on right here, we're going to call this one sinus block. Now here's the difference. If you notice, okay, where they turn back on and compare the two. Here's my 15 box mark, and here's my 15 box mark. My sinus arrest turned on kind of randomly. My sinus block in black here turned on back in line as if nothing happened. Oh, I just had a small little hiccup, but I'm back in pace. I just missed that one beat and I'm back in pace. Or I missed 3 beats and I'm back in pace, but I'll fall back in line. So if you're taking your measurements, right? So if I should be 15 boxes, but I miss a beat and then it turns back on, this amount of boxes here is going to be 30, right? 15 and 15, and there it is. That's not the case with sinus arrest. It kind of randomly turns on after it misses that one complete cycle. So for here, maybe it's 15 plus 8 boxes, right? So you got 23 boxes there. Okay. So your sinus arrest will not fall back in line, but your sinus block will. All right. Okay. So we talked about our escape rhythms already. We have our atrial, junctional, and ventricular escape rhythms. Well, what happens if you just have one escape beat, right? One escape beat. Well, that's pretty simple. That's just telling us that that's telling us that after our sinus arrest, right, here's my P prime, okay? After that exit beat, I'm going to go back to sinus rhythm after that one. Perfect. Now I'm back into sinus. So the only hiccup I had was this sinus arrest here. But you know what? I had my backup pacing methods here, and my atrial cell overcame overdrive suppression, or escaped overdrive suppression, to fire one time. And then guess what? The sinus node turned back on and said, oops, I'm back at it. I'm back in the game. And that's what happens here. Okay. So this is normal sinus rhythm, right? Because 15 boxes, this means this is 100 beats per minute. All right, normal sinus rhythm with sinus arrest and an atrial, right? Because I have a P wave, a P prime, escape beat or rhythm. Well, one beat, so escape beat. All right, so sinus arrest and atrial escape beat. But again, because it's an escape, I could just get rid of this, right? And I could just say normal sinus rhythm with atrial escape beat, okay? All right. If this turned into a different rhythm like atrial fibrillation or atrial flutter, then I would add that at the end. I would say normal sinus rhythm with atrial escape beat, okay? And then I'd do something like an arrow, or say converting to, because now we have a change in rhythm, maybe AFib. Okay, but that doesn't happen here. It stays sinus, so I'll just call it normal sinus rhythm with atrial escape beat. And then we'll move on. Okay, so that one atrial cell escapes overdrive suppression to fire one time and then get you back in line. So what happens if it's a junctional one? Well, then let's just do this. Get rid of that P wave. And for our second example of a junctional, let's make it an upside down inverted P wave. So we'll say inverted P prime. And now this becomes not atrial, but junctional. Okay. All right, so now we have normal sinus rhythm with a sinus arrest and a junctional escape beat, or normal sinus rhythm with a junctional escape beat. Okay. And again, this is just being able to identify the differences between sinus, atrial, junctional, and ventricular. All right, and then finally, we'll do our ventricular beat. And now we have normal sinus rhythm with sinus arrest and a ventricular escape beat, right? Or normal sinus rhythm with ventricular escape beat. Okay. And those will be our escape beats. So on the PowerPoint here, you're going to see that talking about junctional escape rhythms and junctional escape beats, we've already broken that down on our whiteboard here. Okay. Making sure that we're identifying our different types and different shapes of beats, ensuring that they kind of are in line with the inherent rates that each cell will fire at. Yeah. So 60 to 80, 40 to 60, 20 to 40. Okay. So we talked about our junctional escape beats. So we missed our sinus beat, and then we'll get a junctional beat there, and then our ventricular escape rhythms. So oftentimes, when you have these types of beats and they're continuous, like the one I gave an example of earlier, just a second ago, where we had that ventricular rhythm. The other term is idioventricular rhythm. Okay. Oftentimes you're going to see this in a complete heart block, a complete conduction block, where you're not getting communication from the atrium and the ventricle. Think about getting the phone wires cut from one room to another, or you're getting your internet service interrupted from the server to your house, okay, or from the router to your television. Okay, so there's a cut there. Right. If you're looking on the PowerPoint on slide 33, that's a depiction of a ventricular escape rhythm. You have no P waves, okay, and you have a really wide QRS complex. All right, so remember, this is what I call delayed or late beats or late abnormalities. Okay, so if you have an escape beat that happens one time, we call it an escape beat, or what we would say as it's late. It didn't show up on time. It should have been here, but it was late. Okay, now we're going to talk about the early beats. The early beats. Now these are what we call premature beats. So they arrive too soon. So instead of being here, it's going to be to the left. So let's talk about those. And I'm sure now that you're understanding a little bit more about how to analyze and identify these different types of rhythms or different types of beats, right, from the sinus, atrial, junctional, and ventricular areas, this is going to become a lot easier now. So now instead of being late on this backside over here, we're going to be early. So for premature beats, we're going to have premature atrial beats, premature junctional beats, and premature ventricular beats. We like to abbreviate them with PAC, premature atrial contraction, PJC, premature junctional contraction, and PVC, premature ventricular contractions. So let's talk about why these kind of occur a little bit. Well, our premature atrial and junctional contractions, well, they are a little bit more irritable, okay? They're susceptible to epinephrine, some type of adrenaline-like hormones, neurotransmitters, which will then stimulate them to be a little bit more active. Okay, so we'll see them more frequently when we have more sympathetic stimulation. Okay, things like caffeine, drugs like amphetamines, cocaine, or other beta-1 stimulators. So another beta-1 stimulator might be like an albuterol inhaler. That's going to increase the sympathetic nervous system response. And if that happens, that can increase your risk for more PACs or PJCs. Other causes that might give you an increase in PACs and PJCs are hyperthyroidism, hypoxia, and stretch on that myocardium that we kind of discussed before. So in a PAC or a PAB, right? So let's talk premature now. Okay. So we're going to go atrial. We're going to call it a PAC. For junctional, we'll call it PJC. And ventricular PVC. So this is what we call, like, if you've ever heard somebody say, oh, I have palpitations, or I have skipped beats. That's what they're talking about. They're referring to premature beats typically. Okay. And again, like we said earlier, sometimes you will feel these and sometimes you won't. Okay. So in a PAC, we're going to have a P prime. Why? Because it's not going to come from the sinus node and it's going to come early. Sometimes it might be here in the T wave. Sometimes it's just here. It all depends. So if it's in the T wave, you're going to see something like this. Where this is your P prime, okay? And then you have your normal QRS and T. Normal QRS and T. Well, I'm supposed to have 15 boxes between QRS complexes. Well, here it looks like I only have maybe 9. It's a premature beat. Then what might happen is it just waits until it goes back to its normal rhythm, all the way over there. And it falls back in line. You can have one PAC and then it goes back, or maybe you have a second PAC. All right, and let's call this one, this is P prime 1. Well, let's pretend that this has the same kind of shape. And this is coming from the same cell, P prime 1 also. Clean this up a little bit. All right. So this is 9 boxes. And this is, let's call it 11 boxes. Okay. So now I have 2 PACs. All right. So I have 2 POC. Right? Now I have 2 PACs. 2 PACs. Okay, so I have normal sinus rhythm with 1, 2 PACs, and then over here I went back to normal sinus rhythm. So I would call it normal sinus rhythm with 2 PACs. And then I calculate the rate there, right? I'm not going to call this a separate rhythm. I just know that they're early, right? So I'm just going to call this normal sinus rhythm with 2 PACs, and I'm still going to call it 100 beats per minute. And we'll go over a lot more examples in class dealing with these premature beats. So just hang tight. We won't call this a specific rhythm. Okay. All right, so we have two PACs. All right, so now what happens is, well, what if it's not a PAC? What if it's a PJC? Well, let's have a little bit of fun now, and let's do this. I'm gonna get rid of this spacing here, because I think we all understand now that these types of beats are due to premature contractions or premature stimulus, earlier stimuli than we should have. So I have here one PAC, two PAC. And again, when we're talking about PJCs, if I do something as simple as do this, this now changes my interpretation. I now have normal sinus rhythm with one PAC because I have a P prime. Let's just erase that. We're going to call it P prime. And then this one, there's no P wave. So I have one PAC and one PJC. So I'm going to do this. One PAC and one PJC. Okay. It's simple like that. You identify what type of beat you have, and then you add it into your interpretation. All right. So now let's do our ventricles, our ventriculars, our PVCs. For this one, I'm going to kind of go back to where we had before. I'm going to finish my beat here. Okay. And I'm going to add one of those. And again, my 15 boxes is here. Well, we'll call it here. Okay. And then I continue on back into sinus. Okay. So in this example, I'm going to have normal sinus rhythm with one PVC. One PVC. Okay. And those are going to be our premature beats. It's going to be as simple as making sure that you can identify what shapes these beats are based on where they originate from. So based on if you have a P wave, if you have a P prime, if you have no P wave, if it's upside down, or if you have a wide QRS complex without any P. All right, so here in the PowerPoint, we're going to go through our premature atrial contractions, our junctionals, and our ventriculars. So again, here on slide number 38, or yes, 38, you're going to see that we're having PACs as well as PJCs in here. You have one cell that's actually inverted, so we'll call that one a PJC. All right. Now in this strip here, you're going to be able to identify, hey, you have two early beats. Okay, you're having two early beats. Their second beat and your fourth beat, okay, are early. 5, 6, 7, 8, and also your ninth beat. So you actually have three PACs here on slide 39. And you're going to be able to identify that your P waves in those early beats are actually embedded into the T wave. They're embedded into the T wave. Okay, so in beat number 1, that T wave has an additional little spike on the top. Okay, and beat number 3, that T wave has an additional spike on the top. Okay, and in number 8, that T wave has a spike on the top too. Those little spikes are your actual P waves from the beats after. Okay, so your PJCs, which we've talked about before as, hey, I can have no P wave or an inverted P wave. Well, when I get that inverted P wave, it's due to this retrograde atrial depolarization, where it's close to the AV node, and once it fires, it goes down into the ventricles, but it also goes backwards and up into the atrium. Okay. On slide 42, you're going to see a junctional rhythm, right? So this is going to be considered what we call a junctional escape rhythm, because it's a consistent equal distance space, right, R to R, a regular rhythm. However, we're going to identify it based on the type of beats they are. Well, they're inverted P waves tells me it comes from the junction. So now let's talk about PVCs. Your PVCs, a lot of times they occur due to abnormalities, low oxygen in the heart muscle, so hypoxia, airway obstructions, if you're just out of air, right, maybe in a poor oxygen content areas, so like if you're at higher altitude, you might be higher susceptible to PVCs. Poor hemoglobin, poor oxygenation within the blood, reduced cardiac output, so if your heart muscle is actually a little bit weaker, okay, and again, that poor coronary blood flow. Low potassium, some other pathological issues are mitral valve prolapse, myocarditis, which actually a lot of people are starting to develop following COVID-19, and some additional stretch on that myocardium. Those are some things that can lead to more PVCs. All right, so how do you identify these PVCs? Well, kind of similarly to our ventricular beats, we call them wide. Well, a PVC is going to be classified as wide and bizarre. Wide, how wide is wide? Well, remember our normal QRS complex, our QRS interval should be less than 0.12 seconds. If a QRS interval is greater than 0.12 seconds and it arrives early, right? It is premature, enormous amplitude, okay? We're going to call it a PVC, right? What happened when it came late? Well, that was an escape beat or an escape rhythm is what we're looking at. A lot of times these PVCs are of opposite polarity, so maybe not necessarily like that one, but maybe upside down, like one of the other ones that I've drawn on the board earlier. Okay, so with each PVC, we're actually getting a reduction in the amount of blood, amount of stroke volume that goes out from the left ventricle. So after the first PVC that you might have, only 80% of the predicted amount of blood from stroke volume is going to actually be ejected out to the periphery. And if I get two back to back, like this, now at this point, when I have two back to back like that, I'm only going to get 58% of the blood that's supposed to go out of the ventricles out to the body. Okay, and there's a special name for this when we have two back to back like this, right? We call this a couplet. A couplet. So on slide 46, you're going to see three different PVCs on this one. You have a normal sinus rhythm, and then you have two PVCs that face down, and then one PVC that faces up. So this tells me that I have two different cells within the ventricles that are firing. Two fire from one below, maybe, or somewhere else. Two fire from one, and one fires from another for a total of three. So if we ever see something like that, we're going to call this a little bit different name. Okay. So let's say we have something like what's on the PowerPoint slide, where we have one PVC that way, then you have a normal beat here. Okay. And then another PVC, but it goes this way. All right. This is not called a couplet. We're just going to call this two PVCs. All right. So two PVCs. But because we identify that they're coming from different parts of the ventricle because their shapes are different, we have to call it a multifocal PVCs. So we'll call it multifocal PVCs. Multi means multiple. Foci, or focal, refers to cells, heart cells. So this is a different cell than this one. How can I tell? The shapes are different. The shapes are different. Okay. Okay, so the next topic we're going to talk about is specifically with regards to PVCs. Okay. I'm going to draw a little bit backwards here. All right. Just bear with me. We're going to start from left to right, where we're identifying this one here as a sinus beat because we have a P, QRS, and T. QRS is normal width. Then we have a PVC. So PVC, normal, PVC, normal, PVC. Okay. We call this pattern where you have one normal beat, one PVC, one normal beat, one PVC, one normal beat, one PVC. We title this ventricular bigeminy. Okay, ventricular bigeminy. And this is going to be on slide 47. Okay. So bigeminy is a pattern that you're going to see where you have one normal beat, one abnormal beat, one normal beat, one abnormal beat, one normal beat, one abnormal beat. Okay. Now the cool thing is, again, we can substitute any one of these into where these abnormal beats are. So right now we have ventricular. Why? Because it's a PVC. So this is ventricular bigeminy. Ventricular bigeminy. If I were to do this and put these up here, right, put those in there, then this would make it atrial bigeminy. And that would look like this. Now, because I've identified that those premature beats are atrial beats, this is now atrial bigeminy. Okay? Atrial bigeminy. And then to make it junctional bigeminy, if you come across and you don't see P waves or they're inverted, then it's now junctional bigeminy. So bigeminy is one normal, one abnormal. Okay. And then you're just going to substitute your atrial junctional ventriculars for your abnormals. So you can have atrial bigeminy, junctional bigeminy, or ventricular bigeminy, as we just displayed. Okay. Now you can also have trigeminy and quadrigeminy. And again, all you're going to do now is you're going to substitute that abnormal beat for your either PAC, PJC, or PVC. Okay, but let's talk about that really quick. So your trigeminies is one normal, two normal, one abnormal. Okay, so two normal, one abnormal. So let's draw that really quick. I'll get rid of this. So I'm going to actually leave that blank because that's where our abnormal is going to be. Leave that blank because that's where our abnormal is going to be. Okay. So 2 normal beats, 1 abnormal beat, 2 normal beats, 1 abnormal beat, and that pattern will continue. And all you're going to do is you're going to enter here, or you're going to identify which beat you have. Is it a PAC? Is it a PJC? Or is it a PVC? Okay. If it's a PAC, right, then you have 2 normal beats, 1 PAC, 2 normal beats, 1 PAC, 2 normal beats, 1 PAC. That would be atrial trigeminy. If you identify it as a PJC, then it's junctional trigeminy if it's 2 normal, 1 PJC, 2 normal, 1 PJC, 2 normal, 1 PJC. And then ventricular trigeminy if it's 2 normal, 1 PVC, 2 normal, 1 PVC. That same pattern is then true for atrial, junctional, and ventricular quadrigemini, where you would have 3 normal beats, 1, 2, 3, then abnormal beat, 1, 2, 3, abnormal beat. Okay. On slide 48, we talked about, or 46, 48, we talk about unifocal, right? Unifocal refers to coming from one cell, one specific heart cell, okay? Specifically for atrial, junctional, ventricular premature beats. And then multifocal, meaning coming from different cells, atrial, junctional, and ventricular. Then just a second ago, we talked about 2 back-to-back PVCs, right? When we have them fall right back in line, 2 back-to-back, where we're only getting 50% of that blood out. We call that a couplet. So that's 2 PVCs in a row. If I have 3 PVCs specifically in a row, whether it's unifocal or multifocal, 3 or more PVCs in a row is classified by definition as a new rhythm called ventricular tachycardia. Okay, so it could be 3 beats or it could be 10 beats. So your job is to identify how many beats you have of ventricular tachycardia. Okay. Oftentimes, we call it a little bit, it's called malignant. The rule of malignancy means we have 6 or more within 1 minute. Okay. Also, if we have multiple PVCs, multiple runs of consecutive PVCs, if they are multifocal, or if we have a PVC that lands on a T wave, it's a little bit more dangerous. Okay. All right, folks, that's the first part of rhythms and rhythm interpretation. We're going to talk about chapter 6 and go into a little bit more detail with other types of rhythms. All right, folks, if you have any questions, be prepared to ask them in class. And again, we're going to do some practice EKG strips in class together. That way you've watched the video and now you can come in and practice by hand in class. All right, folks, see you next time. Bye-bye.